So thank you for being here. This is the first webinar of the peer-led series of the Boost project. Lynn will help us with the slide transition. So if you can start screening it, I appreciate. Thank you. This peer-to-peer capacity building has been organized by me and John Melhus. You will introduce your input work also in this project and as a network. I'll give a fast overview and short about the Boost. Lynn, can you skip it? So we will have more series around this webinar series that ensure that community is also engaged in any part of the Boost project. The Boost project is a EU for Health project. Lynn, can you just move it, please? Again. Yeah, that's basically aims to address gaps that are still exist in HIV and viral hepatitis around capacity building and advocacy. This project is directed to people who use drugs. As we know, there are a lot of field initiatives around harm reduction that address communicable diseases. And as Aaron put, we are here to ensure that the community is participating in any part of the project. This is a project managed by Correlation Network. Aero Input is a subcontract partner, and yeah, we are participating in all the work packages of the project, as we'll give you an overview from now. Can you pass the slide? So the Boost has as objectives to inform, collection of information and data on community-based services for people who use drugs, improve the organization of capacity building in the field of communicable diseases, and to supporting a scale-up of integrated community-based youth practices, connect and act, consolidating networks of people who use drugs and fostering advocacy. Can you skip again? Okay, so now I'll give the word to John. He will introduce your input work.
Hello, everybody. My name is John Melhus. I'm the peer-led harm reduction project manager for Euroinput. Euroinput is a network, is the network, European network of people who use drugs. Our objectives are to enable people who use drugs to be meaningfully involved in the design, delivery, and review of drugs policy and practice in Europe, and to support user organizations to mobilize together across Europe to promote the health and defend the rights of people who use drugs. Could you change slide, please? Right. In the network, in the organization of Europehood, we have 7 working groups, 7 projects with 7 project managers. We have the network strengthening project. We have the drug user organization development project. We have the OAT project. We have, not to forget, the Sister and Wood and the Euroinput campaigns team and the advocacy team. And lastly, the peer-led harm reduction team. Can you change slide, please? In the peer-led harm reduction team, we have made some, I think, 4 resources that we are promoting and disseminating. The first one we released in 2022, I think it was, those peer-to-peer distribution of naloxone. Then we've this year actually officially launched, the community-led approaches to HIV, testing, treatment, and care, technical briefing, and the peer-to-peer needle and syringe programs technical briefing. We'll be coming back to both of those two a little bit later, but we also have a fourth resource. Change the slide, please, which is the Euro Input peer-led harm reduction uh, safer injecting course, which I'll be talking a little bit about. It's a one-day training course and trainings manual, and it will be officially launched in Warsaw during the European Harm Reduction Conference in December this year. Change. So the safer injecting course consists of four sessions. The first sessions is kind of like introductions, getting to know one another, and to have a little bit of a consciousness about why some people are injecting, why people are injecting, and why people go into injecting, and yeah, just go through the whole course. And the second session, please change, is where we go into detail. I mean, I think the objective of the safer injecting course is not only to give people the knowledge, but also through that knowledge one gets power over one's own use, over one's own yeah, way of using, etc. And which also again creates a kind of like a consciousness to do things more safely. So in the second session, we talk a little bit about the circulation system, about the veins and arteries, about the vein health, where people inject. And we've chosen in this course not to go into the red areas of the groin and the neck, for example. We think that deserves specialized training for people. Please change. And in the third session, we get into the nitty-gritty of injecting, as it were, over applying a tourniquet, about preparing the drugs, about heating up your drugs and adding vitamin C, etc. Also, I mean, just the tiniest of things we've learned through research that the tiniest things like bevel of the needle up or down makes a big difference. So we talk about generally a lot about yeah, taking the drugs themselves. We even talk about needle sizes, etc. Um, in the fourth session, we talk about the distribution and disposal of injecting equipment. And I think Matt Southwell will take you a little bit more through the distribution of injecting equipment a little bit later on. But basically, we have a short introduction to that and about, peer groups going out and cleaning up the area, for example. That's one thing that user groups can do. Is just walk around and clean up all the needles lying around, if that is the case. And we talk a little bit about, safely, how do you dispose of your needles and syringes and such in a safe way. Next one, please. And that was it, actually, about the safer injecting course. I'd like now to hand over the show to Lynn, I think.
Thank you, John. Thanks, everybody. Thanks for coming. So as John introduced our peer-led harm reduction series, this would be the other technical briefing, one of the other technical briefings in the series, which is the community-led approaches to HCV testing, treatment, and care. And this was developed specifically during the Boost project that we're in the middle of now. So there's the QR code there if you want to scan it, and you can access it on our website. So the HCV testing, treatment, and care technical briefing looks at two best practices, Portugal and Norway. Later on, Malu Salazar is going to talk about GAT and the best practice in Portugal. But just to mention that the collection of this best practice took place in June 2023 in Portugal, combining with my attendance at the EMCDDA, now the EUDA Drug Policy Summer School. The interviews were conducted at GAT and at the Manus Safer Space, and I would just like to thank all the interviewees for their expertise and for Joanna Canedo for the translation interpretation work, which without I wouldn't have been able to capture the expertise. So that was a very important piece of that. So Manus Safer Space is a drug user group of women based in Lisbon. And the other best practice that we collected for this resource was Norway. The organization that we worked with was Prolar, and actually John did this collection of the best practice. But basically, there is a mobile bus in Norway called the hepatitis bus that goes around and connects with folks rurally and out to reach people outside the urban centers. It provides diagnostic testing, and then it can, in cases of a positive test, provide ultrasound of liver, and also works with people to do follow-up. So the impact of the bus, there's a lot of connections being built, both with people who need the service, but also with service providers like doctors and healthcare facilities across Norway. So Prolo does this very important work, and there's some pictures there of the bus and of Ronnie, one of the folks that works there. So I've just got a short video, I think, to show you on the hepatitis bus. See if it works. I might need to share my audio to make this work because I've run into this before. So let me just see. Bear with me 1 second. Okay, here we go.
I Norge kan så mange som 15 000 mennesker være smittet av hepatitt C. De står i fare for å utvikle leverskader og i verste fall leverkreft. Hepatitt C kan være dødelig. Problemet er at mange ikke vet at de er smittet.
Skal til Lillestrøm. Noe av problemet i forhold til lever og hepatitt C var at folk med rusproblemer ikke kom seg til sykehuset. Så da tenkte vi at vi kunne lage et prosjekt hvor vi oppsøker de da. Hepatitt C har jo blitt betegnet som den stille epidemien. Viruset kan ligge latent i mange, mange år før man utvikler skade på det. Noe som gjør at det er vanskelig å oppdage.
Hepatitt C er en betennelse i leveren, forårsaket av et virus, HIV. Viruset smitter gjennom blod, derfor er injiserende rusavhengige spesielt utsatt. Mange med infeksjonen får ingen symptomer, men for noen vil infeksjonen vedvare og kunne bli kronisk. I noen tilfeller kan det bli svært alvorlig og føre til utstrakt leverskade og leversvikt, eller leverkreft.
Den gode nyheten er at nå har vi behandling som virker på et helt annet nivå enn tidligere, og som vi også har gjort tilgjengelig.
Vi har fått en veldig effektiv og grei behandling, og det hadde vi ikke før. Da hadde vi en komplisert og ubehagelig behandling. Nå har vi en veldig effektiv behandling, og det gjør det også mye mer realistisk å ta dette problemet med rota og behandle alle som er infisert med hepatitt C. Veldig effektive. 1 tablett om dagen, 12 uker, og så å si alle blir bra. Det kan egentlig ikke bli bedre. Så det er en medisinsk solskinnshistorie.
Men det hjelper ikke med behandling hvis en ikke vet at en har hepatitt C. Og det å få folk til å teste seg, det er ikke alltid like enkelt.
Alle som har hepatitt C, gjerne i tidlig stadium, bør få behandling.
Denne bussen driftes jo av vår brukerorganisasjon, og det betyr at bussen og prosjektet er brukerstyrt. Og det vil si at vi som jobber på bussen er tidligere rusavhengige, og at det er vi som har satt i gang dette prosjektet da. Hei, gikk bra.
Ja, det gjorde det. Altså. Veldig bra opplegg.
God dagen. Hei.
Erik.
Ronny.
Er det her en kan ta sånn hepatittest?
Det kan du gjøre.
Ja, ok. Hei.
Hallo.
Erik.
Solveig. Hyggelig.
Og så er jeg LAR, og jeg har vært rusfri i 10 år nå. Jeg går på Subutex, og nå det siste så har jeg tenkt at det kunne være lurt å ta en hepatittest. Jeg tok en test når jeg fortsatt var rusavhengig, men jeg tok ikke oppfølgingstesten.
Ja, men jeg tenker vi kan ta en kontroll. Hvis jeg fyller ut litt informasjon om deg først, og så skal vi ta et lite stikk i fingeren.
Ok.
Ja, og så da får vi svar på blodprøven innen en time.
Wow.
Og så skal vi ta ultralyd av leveren.
Aha, ok.
Ja.
Da gjør vi det.
Yes. Det er veldig viktig å ha et ambulerende tilbud for denne pasientgruppa. Å ha en sykehusavtale klokka 8 eller klokka 10 er vanskelig. Nå er vi en buss som står og tar imot, altså nett når det passer for pasientgruppa da. Kommer det et lite stikk.
For et par år siden var det vanskeligere å få behandling for hepatitt C hvis du ruset deg. Nå har man endret på kriteriene og gjort behandlingen tilgjengelig for alle.
Sånn. Er det greit?
Ja da.
Ja.
Det er jo en gruppe som faller mellom alle stolene. Det er en brukergruppe som ikke bryr seg om det som er innvendig. De har nok med å leve det som de trenger, og det utvendige.
Sånn. Da er det ca. en time, så er vi klar. Men da kan vi ta den fibroscannen. Ja. Kommer det litt kaldgelé. Så ikke det alltid like enkelt å finne leveren.
Nei.
Så da må jeg lete litt først. Da kommer det et lite dunk. Er det greit? Ja. Det var siste.
Vi tenkte at det må være viktig å ha et prosjekt som oppsøker brukerne der hvor de er. Sånn at når vi møter dem, så blir det mye kjappere en god relasjon, og det er trygghet, og man har tillit sånn veldig tidlig.
Da har jeg fått svaret på blodprøven din. Du var positiv.
Ok.
Så du har hepatitt C.
Jeg hadde jo en mistanke om det.
Det går fort godt dette her. Altså, du hadde ikke noe utslag på prøvene dine, altså på leverprøven din. Det er en 12 ukers tablettkur. En tablett til dagen. Noen kjenner litt på hodepine. Men hvis du drikker nok med vann, så går det greit.
Så det er ikke noe verre enn hodepine?
Nei. Flott.
Tusen takk for meg.
Takk for at du kom, og lykke til videre.
Jeg er veldig glad for at jeg kom.
Du, jeg har hatt en kar her inne i dag. Vi tok fibroscan og blodprøve. Han var positiv på prøven.
Dersom prøvesvaret er positivt, kontakter vi nærmeste helsepersonell for igangsetting av behandling.
Ja, ha det.
Vi ønsker å være med på å bidra til at myndighetene får eliminert det viruset her for godt, da.
Jeg synes det er viktig å si en enkel ting. At alle som noen gang har tatt stoff med sprøyte, de må få testet seg for hepatitt C.
Tusen takk for den viktige jobben dere gjør, og jeg er veldig glad for at dere også skal fortsette jobben neste år. Lykke til videre.
Right, so that was the video on the hepatitis bus, and I think it's an amazing initiative. And like, you know, Ronnie said in the video, it meets people where they're at. It creates this connection between the people getting the service who need support and the service providers. So yeah, it's a symbol of hope in Norway's fight against HCV. And I just saw that the link for the video is put in the chat as well, so you can share it with other folks. So I won't talk too much longer. Just briefly, there were some similarities and differences between the collections of best practice between Norway and Portugal. So Both Norway and Portugal were picked as best practice for this document because they have successfully integrated peer workers into their initiatives. So peer-led interventions have played a crucial role in establishing trust, fostering connections with marginalized populations, and providing support through the HCV testing and treatment processes. Both initiatives recognize the importance of reaching out to vulnerable populations facing barriers to traditional healthcare access. Norway's hepatitis bus travels to various locations, while Portugal's Inmoraria focuses on low-threshold peer-led services. So community engagement and collaboration with local stakeholders are a similarity between the two services. However, Norway is a mobile bus, Portugal is more of a static site, so there's a difference there. And also the countries have a difference in level of financial support from national government health programs. Yeah, and I'll end there, and I think I will pass on to Matt Southwell, please, if you're there.
Hello. So someone got showing the slides. Are they?
Yeah, your slides are there.
Perfect. Okay. So fantastic. So sorry, maybe I'm in the wrong screen. That's probably what's going on.
Sorry, Matt. I adjusted your slides with a boost background.
Perfect. No, I was in the wrong screen, John. That was my confusion. No, thank you for making it look more pretty. That's great. Perfect. Thank you very much for inviting me to come and talk about this great resource from EuroEmpid. It's part of this series that John and Lynn have been talking about. I think what it provides is this really powerful documenting of community-led responses in a number of different domains. This study, which was launched at the INSU conference, sets out the one particular case study and then a series of other case studies around it. It's funded by the Robert Carr Fund, and it's also being used as part of this Boost study. So let's go to the next slide. So it's built around this central case study from Bath in the west of England. The Bath case study came out of a concern among people who use drugs in Bath at the restrictions that were about to be introduced during the COVID-19 lockdown. We were already worried that the integration of needle and syringe programs with drug treatment was leading many people who use drugs to stay away from needle and syringe programs, predominantly using pharmacy needle and syringe programs, which have a very limited range of equipment. So working with local peers, I brokered a relationship with the local service, and we were able to deliver. We now deliver about 1,500 needles and syringes every month through. We give out needles and syringes to 10 or 15 peers who then onward distribute to other peers in the local community. It's a very successful scheme. It's run completely on a voluntary basis. We have been asking for £2,500 of funding a year so that we can run an incentivised peer work programme. And then we think that peers could play a much more active role in facilitating hepatitis C testing. We're just about to have a conversation. Sadly, the local services are unwilling to fund an incentivised peer work programme, which I think reflects the UK's discomfort with models of active peer work, and it also highlights the financial pressures that services are undoubtedly also under. So I think one of the key things about the Bath scheme is, despite the fact that we would like to develop it further and have peers playing a more dynamic and informed role, one of the challenges one of the benefits that's come from this scheme is that while needle and syringe program manufacturers report somewhere between 20 and 50% reductions in needle and syringe coverage during the COVID-19 pandemic in the UK. And that's stubbornly not gone up since the pandemic. Bath is the real exception to that story, where we've actually increased coverage through the involvement of local drug suppliers and other peer leaders who've managed to help us distribute needles and syringes through community networks. One of my concerns is because we don't have fixed site needle and syringe, well, we don't have dynamic fixed site needle and syringe program that would be recognised in Europe with a sort of low threshold drop-in centre. It means that we're not influencing the culture among people who use drugs. So people carry on injecting drugs in quite unsterile ways without washing their hands. And that means that the biggest killer among people who inject drugs locally remains sepsis. And I think it highlights the fact that if you give out needles and syringes, but you're not doing that background education, then that's a challenge. And I think that's why the important peer work education intervention that John described is also another important adjunct. We have to educate people, we have to equip people and also educate people at the same time. So let's go on to the next slide. So the Bath slide is described as the sort of this case study of a secondary needle and syringe program, a scheme that's supported by a local service, but running through a local drug using community. Alongside that central story, we have a series of, I think, 7 other case studies from around Europe and around the world that tell other parts of the story. So first we have really the origin story of needle and syringe program from the Netherlands. And this is where Nico Adriaan and his peers at the Junkersbund in Rotterdam, they ran really, I think what's probably is arguably the world's first needle and syringe program. It was really distributing needles and syringes on an outreach basis through local peer networks. And that then preceded the first fixed site needle and syringe program run by MDHD in Amsterdam. Then we also tell the story of the REUS project from Catalonia, or REUS, the project from REUS in Catalonia, which is another peer-to-peer NSP program. And very sadly, since this project was documented, this one of what was really an outstanding model of community-led harm reduction is sadly closed. And this is, I think, really highlights the challenges of sustaining harm reduction. Where we have had integrated harm reduction, it becomes very vulnerable. Community-led harm reduction, it becomes very vulnerable to funding cuts as policy changes or service models are redefined. However, we can also see that in contexts like the Netherlands, for example, sorry, not the Netherlands, in contexts like New Zealand, for example, and also this is followed out in other parts of Australia, into other parts of the Pacific in Australia as well, where we see actually drug user groups delivering needle and syringe programs, not on the margins of the response, but actually as core parts of the response. So the needle and syringe program network in New Zealand is exclusively run by people or by drug user organizations. Interestingly, they're not publicly seen as like drug user groups as such, but they are clearly peer-run needle and syringe programs. And so some of them are now starting to more publicly identify as drug user groups, which I think shows the different way that drug user groups and peer needle and syringe programs have developed from country to country. So I think the Pacific shows that drug user groups can be very centrally involved. Next slide. In the next slide, John. Oh, sorry, you saw you jumped on, I missed it. Okay, so then, as John's already mentioned, we're talking about the importance of recovering needles and syringes as well. We don't want to make needles and syringes distribution conditional on people returning, but we definitely do want to have an involvement in getting needles and syringes back safely recovered and disposed of. I think one of the pioneering examples is Bruggen Forganen from Copenhagen in Denmark, where the drug users responded to the concerns about needles being disposed in the streets and started to undertake needle patrols. and also had a helpline number where the local community could respond. So drug users became part of the response and part of the solution, not just the problem, or not perceived only as the problem. I think then also importantly highlighting the sort of dynamic street outreach model provided by our friends in Porto in Portugal, and particularly understanding how communities stepped up during the pandemic and really helped needle and syringe access continue. And then because we're documenting good practice models around the world, and these enter the academic literature, this also then leads to drug users being involved in international development settings, as is shown here in Nigeria, where drug users are now central to the response. And the next slide, please. And I think just to finalise, what we really wanted to highlight was that while peer-to-peer NSP remains on the margins, the focus has been globally on highlighting how communities can be involved. And one of the things we wanted to highlight in this work is to recognise that the future of peer-to-peer needle and syringe programs is really drug consumption rooms. And we think there's an opportunity. Many people who use drugs are saying that they don't like over-medicalised, high threshold drug consumption rooms. What we need is low threshold dispersed drug consumption rooms, smaller scale drug consumption rooms run by people who use drugs that are welcoming and friendly. And this would be a real chance to boost the investment in community-led models and peer-to-peer NSP. And then the last slide, just to highlight, as I just press on John, so it's just a few things comes out. Just to highlight that we launched the peer-to-peer NSP technical briefing at the INSU conference in October, and really highlighting peer-to-peer NSP as part of this global commitment in the global AIDS strategy to let communities lead. And I'm very happy that the new WHO guidelines will consider the Euro-input peer-to-peer technical briefing as part of the updated needle and syringe program guidelines that will be worked on this year. Thank you.
Thanks, Matt. Matt, Lynn, John just presented Euro-input peer-led resources. You are much welcome to visit it on our website. I will put the website over here. We have also some guidelines available, and also on naloxone. So peer-to-peer naloxone, it's another resource I would like to mention here. And then as part of the ongoing Boost project and the Euro-input participation, myself, I'm coordinating a survey that wants to become a peer consultation mechanism. We're still in we are first designing this with the 4 lighthouse countries. So Boost works mainly with 4 countries like Finland, Belgium, Czech Republic, and Italy, through the focal points that Correlation has in Helsinki, a clinic, in Antwerpen, a free clinic in Czech Republic, Brno, Punen-Bruges, and Villa Marini in Rome. So these are the 4 lighthouses. And usually, as if you know, Correlation has this European monitoring report where it reports the focal points views on harm reduction services available or not in the cities where the focal points are. So this part of having Euro-input as a partner here, we are consulting the clients and comrades that are in those cities. So we are requesting 30 questionnaires to each one of the peers we work with. So the focal points from the community we have in Helsinki, in Antwerp, Brno, and Rome, and we are training. I've trained them to pass the questionnaires through the 30 participants in each one of the countries. And one of the main aims, can you change the slide link, please? Is to ensure that through the principles of community-led monitoring for people who use drugs and following the principle of nothing about us without us, we are trying to make these co-productions, seeing clients as experts and engaging peers in these stages of the research. As I said, we designed the questionnaire together, so it was a back and forth process with the help also of correlation, because correlation questionnaire has 300 questions, so we minimize the questions for 30. We changed the language also to be more accessible, and we included new topics such as inputs in local drug policy and some other questions around stigma faced by people who use drugs. Of course, the main part of the question is still directed, as the one from correlation, to check the availability, coverage, and quality of harm reduction services in each one of the cities. But with this research feedback, we want to highlight the user's view in 4 main topics. Change. So the access, the coverage, and the quality of harm reduction services for people who use drugs is one of the highlights. The access to prevention, treatment, and care for HIV, hepatitis C, and tuberculosis, stigma and discrimination, and as I said, inputs to local drug policy. So here, so far we have 65 answers. We are still receiving those answers until 20th of November. But the first inputs, for instance, in terms of accessibility, let us see that we are kind of accomplishing the 90-90-90 goals around the HIV and HCV, at least from users' view, on the when it comes to availability of treatment, screening and treatment for HCV and HIV in the 4 countries we are working with. It's something that I was today looking at the data and see how many answers we had so far. This is nothing definitive because we are still working on this. But as part of the implementation phase, I can see some results. Also, we have some open questions that make us an overview of the willingness and priorities for people who use drugs. And drug consumption rooms are mentioned, at least in Finland and Belgium, and I think also in Rome, as part of a service that is still widely wanted by the community, but still not funded or existing in these countries due to legislative or problems with funding or local authorities to implement drug consumption rooms. So here, basically, and just to finalize, we want to bring closer to harm reduction services, but also to local policymakers, and also at the regional level, drug users' opinions and views on the service availability, coverage, but also on policy and practices. Because as peers, we sometimes stay out of the big pictures on the reports at European level, but it happens everywhere that people are not consulted. So in this first phase, we are working with these 4 partners, and if it goes well, we hope to replicate also in the mini lighthouse, which is like other organizations in close countries to these each 4 lighthouses. That's the organizations, A Clinic, Free Clinic, Pollenrus, and Villa Marini are working with, and we'll try to replicate this questionnaire further to engage more data from people who use drugs, and always working by and for and with the community to ensure our viewers are also integrated in main reports. So yeah, from my side is this. I would like to say that in this first phase of this webinar, we presented the resources and the ongoing peer-led research on course. And now I'm very happy to introduce you some practical examples on how our resources can be used and also export to local dimensions, because one of the objectives of being here and as a network, it's enabling local drug users' actions and enabling peer-led services and enabling peer-led initiatives. So I'm happy to introduce Maria Lech and André from Salut, Catalonia. They will talk about how they are using HCV resource that was mainly based on Euro input research, but adapted to a local reality. So welcome, girls.
Hi, hello. ¿Querés empezar?
Go, Maria.
Can
We
you
are not.
listen now?
No.
Hello?
Now, yes, sí. Puedes
Yeah,
empezar.
now you. Okay, voy para allá. We made a comment with with other girls who used to come to Sadu every Tuesday, and about hepatitis C, because it's very important to get information about it, because people they don't really know how it contacts and how dangerous it can be to have this. Maybe you will not notice it immediately, but with the time, the damage on your liver will show in many ways. Like, for example, another hepatitis, like hepatitis B, you can see the sign in the yellow eye, um, the fever and things like that. So we made a comic to explain it and to show how you can see and notice that you have it. So we go on with the comic, right?
Yes. I don't know if you can listen to me because I don't listen you. I don't have the
Earphone.
but I sent it to Sean, and I don't know if Sean, can you share? Okay, perfect.
Yeah, the best way is to see.
Change slide.
There we are.
Andre, we are not listening you very well.
Hold on. Okay. And this. Sorry. And we read together, and we think that it's important to have a document that it's easy for the read and to have with us every time. We talk a lot with Maria and with another woman of the importance of the life experience in this situation to share and to associate others that have the same problem. So we think that it's very important for us, and we had a real good time working in it.
Maria, I don't know if you want to share also the work you do also to go and escort other women to the medical services, because there's something that is written here in the cartoons, but as it is in Spanish, I don't know if everyone understands. So if you want to just say a few words on the work you also do, that is explained actually in the cartoon.
Yeah, here I used to do this since many years. That if I see people who are sick and they stay in a drug flat, or they are addicted and they have a serious problem, and they just don't have time or don't want to go to a doctor or to a hospital. So I used to help these people. I used to I used to go to the place where we get a nurse and doctors. I just tell them this person have this, and that, and then they help me. They give me medication and things so I can help the person. I did it. I'm doing it since many years because I know how it is to be addicted. So if you have a serious problem and you really need to go to a doctor, because it will not go away just smoking a pipe or doing a shoot. It's impossible. But the people, they think, yeah, okay, I smoke or I inject and then it will be better. It will not be better. It will calm for a while, but it's getting worse. So what I used to do here in Barcelona is this. if they don't want to come to the doctor, I bring the doctor there. So yeah, and I'm doing it since many years, and I think it's very important because it happened to me, and then it doesn't matter if it's a wound or if it's a cough or whatever. And thanks to the doctors and the nurse here in Barcelona, it's possible for me to do that. Yeah.
And also thanks to your work as well. So yeah, now I'll pass the word, I think, to Janko, if you don't have anything to add. And thank you for the cartoon. We'll share the cartoon
enjoy
if you
it.
can also to everyone. Thank you both.
Thank you too.
Hello to everyone. I'm Janko from Slovenia. Our network, our NGO, Retribe, is actually not involved in peer-to-peer distribution of syringes. We were distributing syringes till 2021 when we've been evicted from Factory Rock. In that time, we were working with migrants, and we are still working with them. In April this year, we started a questionnaire. Maybe it will evolve in research, I don't know. We are trying to mimic one of the prior researches which we were conducting together with faculty. In the same manner, we are collecting questions about satisfaction with OST and with all harm reduction services around Ljubljana. And we found out that during COVID and after COVID, things change a little bit because people begin to question why there is only syringes. Okay, this project now is dedicated to safer injecting course, but in Slovenia we recognize that for last 30 years we are promoting only syringes. And basically, the most safe way of using drugs is smoking or snorting. So I would like to emphasize that a lot of community is now trying to switch. They are switching. They are not injecting no more. So what is important? Well, this is the result of our last endeavor. We try to organize a self-injecting course, but this 1 week before us, another organization organized it. So we said it will look ludicrous if we organize the same workshop. So that's it. I don't have slides. Maybe next time I will prepare some results of our questionnaire. Well, maybe I can say also that we found out that gypsies, the community of gypsies are really out of the system. They are out of harm reduction system because they are not connected. No NGO is really covering this part of population. That's all, actually. Any questions?
Thanks, Janko. Go ahead, John.
Janko, I would like just to ask you, because the buildup of the community and also the work you do through Ariel and Slovenia, maybe it's also a way to reach out more hidden people use drugs, like the Roman community, as you were saying. So are you planning to do any work around this, or maybe to export this training to these specific
Well,
community?
one idea is we heard that our government will organize around 30 social workers or social care workers to cover the south of Slovenia, because in last few months or weeks there have been some conflicts, even shooting and attack on police. So maybe we will propose to Slovenian government that maybe we can involve in this community. I must say that we are actually in Slovenia non-existing. Since 2008, we have problems with the system, with policy and so on. We are kind of ignored. We don't exist for professional community in Slovenia. We were the first who started, say, from first shelter, first outreach project was started by me in 1998. But I'm ignored, we are ignored, we don't exist because, I don't know, they don't like people who have expertise, I think. Yeah.
Yeah, or either sometimes we need to get back to the past and write our own stories, and also because the most innovative harm reduction initiatives came from drug user community.
Yeah, of course.
So also a reminder on this
and
first, and then I think through these resources we can also target professionals. At least here we try to do this, and I think in any country. And as you forced, may you come to the work together again.
Yeah, I heard you spoke about this research. Maybe we can join forces. I can send. Did you got my questionnaire? No, I send it around to some people. Did you got this questionnaire?
Yeah, the idea is actually to have users use. So now we are trying with these 4 countries, and then we will export, and we are counting all your input members and focal points to help out also to also gather these views. So thank you, Janko. Sometimes it's not easy to implement also the resources we have available, but we also can work together towards overcome these gaps and find opportunities to make it, and addressing it also to specific communities. Now we have Malu from Moradia GAT Lisbon. Malu will be presenting GAT in Moradia as part of the best practices resource. I just leave here the input website where you can find also the reports. So please go and check. Malu.
Hi everyone. My name is Malu. I work in GAT in Moradia in Lisbon. And first of all, I was planning to not be the presenter here, but our peers were not available. But actually, Magda Ferreira is here. So Magda, you are very welcome to add and comment and say anything you want about in Moradia, because I know that you will give a much better perspective and other contributions to my presentation. So I will talk a bit about GAT in Moradia and how we implemented our hepatitis C consultations in our community. So Lynn, can you pass? Thank you. And the next one, please. So GAT is the group of activists in treatments. We exist since 2001, and it's an organization that was created and is also led by people that live with HIV and other infections. And GAT has a lot of services that are directed to different communities. And GAT in Moradia is a harm reduction center for people who use drugs and people who experience homelessness in the historical part of Lisbon in Portugal. So we are a fixed center in a historical neighborhood that has a lot of people who live in the streets, people use drugs, a lot of sex work, and the many migrants also live in the territory. And we exist for 12 years. we are a low threshold service, and we work based on the logic of one-stop shop. So people can have access to various kinds of services in Moraria. So it has an integrated approach, and I will show you the services that we provide. And the staff is multidisciplinary. So since GAT in Moraria opened the doors, we started out as a community-based service. But our main goal, and this is very challenging as well, it's something that we need to reflect on, is how can we build a real community-led service, and how can we implement participatory processes to build the service and to listen and to involve our community. And that's a big challenge that I would like to bring for all of us. So, Lynn, can you? Yes. So this is our in small drawings. I try to show what kind of services that we have in Moraria. Like I told you, as an integrated approach. So we provide social and basic social services, and also health services. So in our drop-in center, people can go and get some rest during the day, some food, some products, hygiene products, some clothes, make some phone calls, go to the internet, have access to their physical mail. But also, meanwhile, in the drop-in, people can ask to go to talk to the fast test for STIs, to have access to injection, snorting, or smoking material, condoms and lubricants. And we are a team that has doctors, nurses, and peers and social workers as well. So people can talk also with our general practice doctor, our psychiatrist. We also have a psychologist, social workers. And there's a central and crucial role in Moraria that are our peers. We have 5 peers working in Moraria presently, and they are the ones who nowadays lead all the interventions of Moraria. And meanwhile, we also try, it's a very horizontal and informal space, and we try to implement ways that we can involve our community while we design the service. You can pass, Lynn. So the idea of bringing a one-stop shop to the community is acknowledging that people who use drugs face a lot of stigma and discrimination while accessing other services, mainstream services. And what we try on a daily basis to build is to bring and to construct non-judgmental, peer-led space where people feel welcomed, not judged, and in order to fight for implement the rights of people who use drugs, we do the opposite way. Like, people don't need to go to the hospital or other services. So we try to bring all these services to the community. So like I told you before, all these services that we provide are ran in a low threshold logic. So there's no appointments, no schedule. People know that these appointments exist, and they go, and it's in order of arrival, the consultations. And we did the same regarding the hepatitis C treatment. So we noticed that there's a high prevalence of hepatitis C infections among people who use drugs that were tested in our center. And but we noticed that people actually after the test, the positive test, actually they wouldn't have access to reach a doctor, to obtain some prescriptions, or even to initiate or to finish the treatment. So what we decided was to bring the doctor and the hospital to our community. Thank you. So prior to the implementation of the project, that was in 2019, we did a small rapid survey about hepatitis C, and we noticed that actually 85% of the people that we interviewed accepted the hospital referral, and only 76% reached the doctor, and only 33% obtained the treatment prescription. We can see these numbers, this cascade falling very abruptly. And however, only 24% actually initiated the treatment, and only 11% completed it. So this shows that people who use drugs face so many barriers to have an effective access to health, that that is important to create these spaces that are led by peers, that peers have a central role doing navigating through the system, doing health education and sharing experiences, and to create a space that people don't feel discriminated while trying to have access to the services. Lynn, can you pass, please? So I'm not going to read all this slide. So it's just to show more or less how we implemented the project. So GAT and the Lisbon Central Hospital, they made a protocol in order to implement the project. The team of GAT in Moraria was trained by actually it's mostly the nurses to be a point of care as after the PCR testing. And then we invested in the peer involvement to ensure the linkage and retention in the decentralized hepatitis C treatment consultations. So peers are very important to spot who people that didn't actually got to the hospital, or didn't want to go, or just felt scared about having hepatitis C, or facing discrimination in the hospital. So peers are very central also in this process. So GAT is responsible to be the point of care, the PCR hepatitis C confirmation of infections. So we have a safe aid, the machine that after the rapid test we can confirm if it's a positive test and if it is really hepatitis C. In GAT in Moraria, the nurse books the decentralized consultation, does the sample collection of analysis, and provides the medication regimen adherence. So which means that the person doesn't need to go anytime during all this process to the hospital. The doctor twice per month comes to our center and provides the prescription and the treatment together with the nurses, and the other peers or other professionals can be also involved as if the person wants to accompany all this process. And then the hospital was responsible to provide the FibroScan that we also have in the center, to give to provide the treatment care and to monitoring, to do the laboratory sample, to the transportation and processing of the laboratory samples that we do take in the center, and to give the medication and transport it to GAT in Moraria. So you can pass, Lynn. So from September 2020 to August 2024, 156 people attended the decentralized consultations, and 72% of the people were cured. This looks like a very low number, but actually, if we consider the 11% that had completed the treatment previously, like I told you, actually the numbers are, it's 46%. And it's always, I think that was Matt or John that said previously, sometimes it's not easy to maintain the sustainability of harm reduction services, especially the ones who are led by peers. And I think these numbers are also something that we can reflect about, is how many challenges our services and our community face in order to maintain this sustainability. So for us, these numbers, despite of not being very, very high, I think that it's a constant fight. So thank you very much. If you have any questions, please ask me or Magda. She knows she can give very important contributions. And thank you.
Thank you, Malu. Magda, are you around? I don't know.
Hello. Yes. Yeah.
Hello.
Good afternoon, you all. And very pleased to hear all these good things. In continuation of what Malu said about GAT in malaria, where I first started when I entered the GAT as a peer worker. The injection there actually started as a civil disobedience act because at the time when we started giving the kids, I told my coordinator that for me as a drug user, I know that that particular person would go and inject alone in a bathroom, and it was visibly full of benzos. So there was a couple of persons, like 5 or 6, that we started by as according with all the team to do some civil disobedience and start doing safe injection in the drop-in. And so we started to do that at the drop-in. Nowadays, actually, the drop-in developed a lot of manners to reach people, even though I have big concerns about one thing in particular that is happening after the pandemic in the Asian community. And I think it would be of major interest to train peers and outreach them to screen because they live in a big stigma even among themselves to disclosure that they turn to injection. A lot of people relapse in injection and they are not being capable of open that use of drug. Sometimes I go with among them to show. Sometimes we have to be one-to-one actually to this undress the shame thing. And as Malu said, the peers and GAT are the main bridge and the main link to adherence to treatment. So what's happening today, and actually concerns me, is that it's becoming normal because of the closing of a lot of pharmacies of distribution of meds for HIV. It's becoming normal and accepted that, oh, my meds and I have to pick up more. And then 1 month passes, 2 months passes, and the people are becoming out of meds, and they are making each time bigger breaks on their adherence to, especially what I see, HIV meds. About hepatitis, what I actually would like to do with Malu, and we have a peer, a Nepalese peer, to give him training and outreach the community to screen hepatitis, and also take that migrant community, because in an exponential way, I believe that it will become in a short period, it will become a widespread hepatitis epidemic again among that community. I think at the moment I don't have any more input.
Thanks, Magda. I think it's very important what you say in terms, we've talked here, it's not the first time this webinar about migrants who use drugs to address specific communities, and we count on every peer to do that as well. So I guess GAT couldn't do the work GAT does without mostly working and having peers as coordinating interventions as well. Not only working with, because any organization can work with peers, but then if we need to guarantee that the peers have the work responding to the expertise. So thank you, Margot.
Yeah, thank you.
I think it's also a good moment to mention that peers in GAT and I guess in ProLAR as well, as part of the best practice, we are taught to do the testing, and also to go through the cascade of care, but we do the testing as well. That's an important part to arrive to certain communities as well. John, I don't know, I think you have something to add by now.
Yes, I just wanted to add very, very shortly to add to Janko's presentation that we do discuss the possibility to switch over from injecting to smoking also in the safer injecting course. And I've added the link to the course here in the chat now. Thank you.